Today's speaker is Dr. Elaine Pierce. Dr. Pierce completed her medical degree at Northwestern University in Chicago. She followed this with an internship at Mount Zion Medical Center in San Francisco and a residency in emergency medicine at UCLA. Following this, she was assistant professor of emergency medicine at Texas Tech University in El Paso and worked as an ER physician in Kaiser, Oregon, and at St. Vincent's Medical Center in Oregon. In November of 2005, she joined the County of San Diego Human Services Agency after completing a master's degree in public health at SDSU. She's currently working there as an epidemiologist. Today's topic is avian flu. Dr. Pierce.
Thank you very much. It's a pleasure to be here. And we have a lot of material to cover, so I will dive right in here. I just want to remind you about the nomenclature to begin with. Remember that the type, avian flu A, B, or C, is determined by the stable internal nuclear proteins, and this is followed by the geographic origin, the laboratory strain number, and the year of isolation. For influenza A only, the highly variable surface glycoproteins, hemagglutinin and neuraminidase, are specified. There are 16 types of hemagglutinin known and 9 types of neuraminidase. Now, the anatomy of the virus is important to understand its function. First of all, it has a segmented genome. It has 8 separate pieces of single-stranded negative sense RNA, each one attached to its own polymerase. The hemagglutinin, as we talked about, is the protein on the surface that allows it to stick to the host cell. Remember that no virus can reproduce itself. All viruses have to hijack the host cell machinery for reproduction. So that's the first step in getting it to stick onto the cell. The neuraminidase is at the other end of the reproductive cycle. It allows the new virions to be released from the host cell. And as it buds out of the host cell, it steals the lipid bilayer membrane from the host cell, so that's the rest of its covering. I just want to say a word about hemagglutinin because that is the principal determinant of pathogenicity. You see here the receptor binding site, and here is the cleavage site. Like many proteins, this is a protoprotein, so it needs to be split into 2 before it's active. And the nature of this cleavage site determines how lethal the strain of influenza is. And this is a funny diagram because the upright chicken is a not-so-sick chicken and the tilted chicken is a dead chicken. So for avian influenza that's of low pathogenicity, LPAI, the hemagglutinin has a cleavage site that is only worked on by protease enzymes in the respiratory and GI tract. So therefore, the infection is restricted to only those 2 organs, and it's not too severe. But in highly pathogenic avian influenzas, such as H5N1, the cleavage site has been replaced with an increased number of basic amino acids. This amino acid substitution allows many more proteases in the host to cleave the hemagglutinin and make it active. Therefore, you magnify tissue tropism, you have a much more disseminated infection that is highly lethal. Another theory about pathogenicity is the so-called cytokine storm theory. It's been noted that extremely high levels of pro-inflammatory cytokines are found in patients with H5N1. And the thinking is that this is a positive feedback loop. The cytokines are not able to set off mechanisms that destroy the virus. Therefore, the body keeps cranking up the production of them until you get an unregulated inflammatory response that actually damages host tissues. Now, let's move to the epidemiology of the virus. First of all, it's aquatic migratory waterfowl that are the reservoir for this organism. So all different types of hemagglutinin and all different types of neuraminidase exist in migratory waterfowl. And a few other species may be susceptible to certain types of hemagglutinin and neuraminidase. So you can see that there's marine mammals here and horses here. Humans, of course, are susceptible to the H1, H2, and H3. And interestingly, pigs also share susceptibility to H1 and H3. Now, these viruses, because migratory waterfowl have been stable reservoirs for this virus for so many millennia, they generally don't get sick with the bug. So they carry it asymptomatically, they shed it in their feces, the virus is quite durable, it lives in the water, and so other birds drink it basically, so it's a fecal-oral spread. By contrast, domestic poultry often gets very sick with avian flu. So a farmer can look at his flock one day and it looks fine, and the next day half the birds are lying on their side gasping for air. So there's a big difference in how wild waterfowl and domestic poultry react to the viruses. And a point I just want to make here is that routine disinfectants are effective at killing avian flu. Just a word about antigenic drift and shift. Drift is minor changes that occur every year. That's why we need a different flu shot every year. By contrast, antigenic shift is a major mutational change that actually changes the hemagglutinin or neuraminidase to a different type. And this is usually what's responsible for a pandemic, a major alteration in the genetic constitution. Now, looking at the pandemics of the last century, the mother of all pandemics was the so-called Spanish flu. That was the first appearance of H1N1. And over 500,000 Americans and up to 100 million people around the world died from this virus. Then in 1957, the Asian flu showed up, which was the first appearance of H2N2. And in that pandemic, 70,000 Americans died. In '68 was the Hong Kong flu, which was H3N2. Notice that the neuraminidase did not change, only the hemagglutinin, and that is postulated to have resulted in a lower mortality for this pandemic. Now, what are the requirements for a pandemic? Three things have to occur. First of all, it must be a completely novel virus to which nobody has any immunological memory. So the H5N1 is that. It has to be highly pathogenic to man, which H5N1 also succeeds in that area. And it needs to be efficiently transmitted between humans. So this is what H5N1 has not learned to do, and it's the one step that's keeping us from a pandemic. Now, the World Health Organization has organized the pandemic in phases. We are currently at phase 3, which means no or very limited human-to-human transmission. Phase 4 is when there's small clusters of human-to-human transmission, i.e. up to 25 people for up to 2 weeks, and then the cluster burns out. Phase 5 is up to 50 people for up to a month, and phase 6 is a pandemic when there's sustained transmission between humans. Now, there are two ways that a pandemic can be initiated. The first way is for the virus just to keep accumulating adaptive mutations. Remember that RNA viruses, similar to HIV, do not have a proofreading function when they replicate, so they have an extremely high mutation rate, which is why you need a different flu shot every year. So if the pandemic comes via sequential mutations, we can expect that kind of stuttering onset of little clusters that burn out so that we will go through phase 3, 4, 5 before we get to 6. On the other hand, if it occurs via reassortment, the pandemic could be very explosive and we could skip phases 4 and 5 and go directly from 3 to 6. Reassortment means that a mixing vessel host, meaning a host that's capable of contracting both avian flu and human flu, gets infected with the two viruses at the same time. And remember, it's got that segmented genome. So these viruses not only mutate a lot, but they will trade entire pieces of RNA. So if the avian flu picks up the genes from the human flu that convey the ability to transmit between humans, it could instantaneously become efficiently transmitted between humans. And man and pigs are the two mixing vessel hosts that can contract both human and avian flu. Now I get a lot of questions about why is everyone so worried now as opposed to 10 years ago. So here are a few thoughts on this. First of all, pandemics are nothing new. They've been recorded in history since the 1500s, and they're usually about 3 per century, and the last one was about 39 years ago. If you've been following the news, you know that H5N1 in wild birds has steadily spread from east to west across the old world. So just since the beginning of this year alone, it's been detected in the Indian subcontinent, the Middle East, most of Western Europe, and a number of countries in Africa. So currently we do not have H5N1 in the New World or in Australia, New Zealand. Another interesting phenomenon is, as I told you, wild birds usually are not affected by avian influenza. They carry them asymptomatically. So a strange phenomenon has been that there have been a number of wild bird die-offs. Notably at Qinghai Lake in China a few years ago, 6,000 bar-headed geese died. You can see this bird is infected because it has diarrhea. And it shows that the ecological balance between the organism and its natural reservoir is off. It's off balance. And the other thing to note here is the large overlap between the Asian fly path and the Western Pacific fly path. And the land mass where the overlap is Alaska. So all the mallard ducks that you see flying northward right now will be going to Alaska, where they will commingle with infected birds from Asia. So what's hotly debated is whether they will return this fall carrying H5N1. Another strange thing that's been happening is that cats have not been known to be susceptible to influenza, but they are highly susceptible to H5N1. For example, 150 tigers died in a Thai breeding zoo a couple of years ago. The initial tigers were fed infected raw chicken, but the subsequent tigers were not. So the thought is that it was mammal-to-mammal transmission, which has also been demonstrated experimentally in ferrets and house cats. And looking at the virulence of the virus from 1997 compared to 2004, the mortality rate in ferrets has gone up from 35% to 82%. So this suggests that we know the virus is changing radically over time, and this suggests that the virulence is going up, not down. So the 1918 Spanish flu, the case fatality rate of that in the United States was 2.5%. It was much higher in other areas, some other areas of the world. For example, some villages in, I believe, Alaska, some of the native villages had mortality rates up to 60%. But overall in the U.S. it was 2.5%. For H5N1, as of yesterday, we've had 207 cases and 115 deaths worldwide. So the mortality rate is over 50%. But I hasten to add, this is the apparent case fatality rate, because the denominator only has people that are sick enough to present for medical care. So obviously what's needed is population-based seroprevalence studies, which amazingly enough have really not been done. So the case fatality rate is likely less than 50%, but it's not going to be a whole lot less, most likely. Now this is kind of an intricate but important slide that I want to show you. This is the 1918 pandemic, this is 1957, 1968, and the next pandemic. So you'll notice that in 1918, the virus was a direct, pure avian flu that learned to transmit to man. Whereas for 1957 and 1968, it was a reassorted flu. So remember, this is H1N1. The pandemic flu always gets tamed afterwards and becomes the dominant regular seasonal flu in the subsequent years. So by 1957, H1N1 was the regular seasonal flu. It picked up 3 RNA strands from an avian flu, and that led to the H2N2 appearance of that pandemic in 57. In 1968, H2N2 was a seasonal flu. It picked up a couple of pieces of RNA from an avian flu, and that led to the H3N2 pandemic. So the question is, what's going to happen with the next pandemic? If the pandemic strain is H5N1, then it will be a pure avian flu, or at least it looks like it will probably be a pure avian flu that learns to transmit to humans. And as such, it's taking the pattern of 1918. Another thing that you've probably seen is that in 1918, the mortality age distribution was very different than usual. Usually this is a U-shaped curve with increased mortality in the very young and the very old, whereas in 1918 there was a big bulge in the 20 to 40-year-old age group. And with H5N1, we are also seeing the mortality pattern primarily in children and young adults. Now, we don't know if this is due to some inherent increased susceptibility of these ages, or whether it's increased risk behaviors, or a combination of both. And I also want to point out that already, because of its rapid mutability, genetic diversity is developing within H5N1. So you have clade 1 in Vietnam, Cambodia, and Thailand, and clade 2 in China and Indonesia. And human deaths have occurred from both varieties. I'd like to say a word about this guy. He's a virologist at the University of Tennessee. He's been studying influenza for over 40 years. When he was a graduate student, he came up with the concept of antigenic drift and shift. He's also the one that discovered that migratory waterfowl are the natural reservoir for the virus. And he's not just an ivory tower scientist. His entire career, he's traveled the world swabbing the cloaca of sick birds. In fact, one time when he was investigating another avian flu that had transmitted to humans, he concocted his own nasal vaccine for that strain of flu. And as his coworkers were asking him, as they were pouring it down their noses, one of them asked him, "Robert, do you think that this virus is really dead?" And he said, "Yeah, well, we'll find out." So this guy knows more about the flu than just about anybody, and he's gutsy. I mean, he's out in the field doing the work. And this is what he says about H5N1. It's the worst virus I've ever seen or worked with or read about. We have to prepare as if we're going to war. So, what are the risk factors for human disease? Well, at this time, you really need to have close contact with diseased birds. Most of the victims have lived with their own household flocks, and they are involved in butchering, defeathering, eviscerating, and otherwise preparing for cooking. There are also exposures that result from cockfighting. As you may know, in cockfighting, large bets of money are placed on these birds, so it's not unusual if a man's bird is losing the fight for the man to suck out bloody secretions from the bird's beak to resuscitate it, and that's been implicated in the disease developing in a few cases. There were a couple of cases in Vietnam where raw duck's blood was consumed, and that was thought to lead to the disease. Also, as I said, the virus is quite durable. It can survive for up to a month in feces, and it's thought that a lot of the pediatric cases have occurred from children playing in the dirt and doing what they usually do, which is having a lot of hand-to-mouth behaviors and picking it up from phone lines. Now, I get a lot of questions about, is it safe to eat chicken? Well, first of all, there's no H5N1 in this continent yet, so that doesn't apply here. But it's comforting to note that there's been no epidemiologic link between eating cooked poultry products and human disease, even in countries where the disease exists in poultry. So you can imagine that this virus with its lipid bilayer is readily killed by heating temperatures, cooking temperatures. The FDA recommends that poultry be cooked to an internal temperature of 165 degrees or greater, and basically all the same safety techniques that you use in your kitchen to prevent Campylobacter or Salmonella would be effective against avian flu. Now, this was an interesting recent article that I want to tell you about. This talks about the 4 methods of duck farming in Thailand. The traditional method is to release your ducks into a rice paddy and wait until they've eaten all the rice and snails, etc. Then put them all in your truck, ship them to a distant province, and do the same thing. So here you have the worst of both worlds. Not only are these ducks commingling with wild waterfowl, but then you're transporting the infection to other parts of the country. So this practice has been banned by the Thai government because in this situation, about half of the ducks became infected with H5N1. The next traditional method of farming is just the backyard flock of mixed birds, and in this situation, half of the chickens had H5N1 and about a quarter of the ducks were infected. The initial attempt at biosecurity was simply to screen the ducks in a screened building so that they can't be in direct contact with wild birds. Unfortunately, this was not adequate. About 23% of the ducks did have H5N1. And this is the most advanced form here. You can see the large fans keep the building cool. There's also restriction on who can enter. Only a small staff can enter. They need to disinfect their boots and wear protective clothing. They also use an all-in, all-out policy where all the ducklings are the same age. They raise them to maturity. They sell the whole lot of them. They disinfect the building before they bring in new birds. And with this practice, no ducks have become infected with H5N1. So I think what this demonstrates is that farm biosecurity works, but it needs to be at a very high level. And that's certainly something that will need to be considered in this country when wild birds become infected with H5N1. So here's the big question. Every new case, this is scrutinized. So the question is, has human-to-human transmission occurred? And the answer is it probably has, but it's very, very limited, and there's been no ongoing transmission beyond the one generation. The best documented case was in Thailand. There was a young girl that lived with her aunt, and she slept in a hammock under the house where the poultry were running around. When she got sick, her mother, who lived in Bangkok and had no other risk factors, came to the hospital and provided close nursing care for her for quite a few days, and she also developed the infection. There have been mixed studies on healthcare workers as to whether their seroprevalence is higher than the regular population. I would add that these are all from 1997, and the virus has changed so much since 1997. I would question how relevant those results are to the current strains of the virus. A few other suspicious family clusters, nothing confirmed. And importantly, even in the most recent outbreaks in Turkey, Indonesia, Iraq, Azerbaijan, and Egypt, all of the people have had direct exposure to sick birds or their secretions. Now let's talk about the clinical appearance of the disease. First of all, you're used to thinking of a very short incubation period for flu, about 48 hours. There's some evidence that the incubation period may be longer for avian flu, perhaps up to a week. Also, people may be contagious about a day before they become symptomatic. The viral load, or viral shedding, I should say, closely follows the fever curve, and the fever tends to peak in the first couple days of the symptomatic infection. Initially, it looks pretty much like regular influenza, with perhaps fewer upper respiratory symptoms. It's been found that the virus really prefers the cell receptors in the lower respiratory tract compared to the upper tract, so you may have less sneezing and congestion and so on. And also there's been noted a higher incidence of GI symptoms than compared with regular flu. Now, in some cases, this has rapidly progressed to viral pneumonia. People can have rales and rhonchi, be short of breath within 4 or 5 days of onset of symptoms. And when the infection is severe, it leads to respiratory failure, secondary multiple organ failure, especially targeting the heart and kidneys, and there may also be neurologic presentations such as an encephalitis picture or coma. So here's x-rays on a child with a fatal case. You can see how within a week's time it progressed from unilateral pneumonia to an ARDS picture. Now, even a non-pathologist could tell that this looks nothing like the normal lacy aerated structure of this. So basically, in severe cases, the lungs turn into a soggy bag filled with blood, inflammatory cells, and interstitial fluid. And special staining reveals that type 2 pneumocytes are specifically under attack from the virus. Now, this is the important part to remember. This is a current case definition, and with any emerging infection, you expect the case definition to change, but this is what it is at the moment. Think of it as 4 components, and every one of them has to be present for it to fit the case definition. So symptom complex, travel history, timing of travel, and risk behaviors. Now the symptom complex is basically a respiratory symptoms, either more severe or less severe. So you can either have pneumonia confirmed by X-ray, ARDS, or other severe respiratory illness for which an alternate diagnosis has not been established. And in these very sick people, there's no question that testing for H5N1 is indicated. Or you may be seeing the patient early in their course or a mild case of it, in which case they may only have a fever greater than 100.4 and one or more of the following: cough, sore throat, shortness of breath. In this situation, testing should be considered on a case-by-case basis in consultation with the local health department. Next comes the travel history. Now, the countries that are recommended to be used for a relevant travel history are those with H5N1 in poultry, not wild birds. Now that the disease is in Western Europe, where they have modern bird husbandry techniques, it's really important to look at poultry disease, not wild bird disease. You can find the list at this website, which I'll show you in a minute, or of course, we at the health department can let you know what it is. And the third factor is that the timing of the travel must be within 10 days of onset of symptoms. So it's important not only to find out where they went, but try and get travel dates and compare it to onset of symptoms. When you go to this website, this is what you'll see. You can see that Vietnam has had by far the highest number of poultry outbreaks, followed by Thailand and Indonesia. And there's a number of other African countries in here. And you're even starting to see one outbreak in France and Germany. So it's all over that range of the old world, basically. Now, the final component of the case definition is risk behaviors. So it's not enough that they just went to those countries at the right time. If they were a tourist staying in a hotel, then they're really not at risk unless there's a specific risk behavior. So they must have at least one of these 4 things. Direct hands-on contact with domestic poultry that could either be well, sick, or dead. Consumption of uncooked poultry products. Direct contact with surfaces contaminated with poultry feces, so that would be bird markets, farms, etc. Or close contact within a meter of a known or suspected human case of H5N1. And since many of these countries do not have advanced laboratory methods, we would accept a suspect case as a history of someone saying, I stayed with my cousin and while I was there he got really sick and couldn't breathe and wound up in the hospital. And that would be good enough to at least initiate considering that this person might fit the case definition. Now, this form is what we use for case screening. So if you're on EMAN, the Emergency Medical Alert Network of San Diego, which I hope that you're all on, you can download most of our forms and look at them, or of course we can always fax them to your office. So what we envision is if you're worried that this person might be a suspect case, give us a call. We'll go through the form with you and discuss it and work on it together to see if this person should be considered a case. Once the patient we do decide this person's a case, there's a 5-page case report form that goes into a lot more detail about exposures, travel itinerary, symptom complex, clinical course, other human contacts, etc. I'd like to emphasize at this time that the Community Epidemiology Department is available to you 24 hours a day, 7 days a week. So we have our regular phone number here and our after-hours phone number here, and you'll speak to the epidemiologist on call if you call after hours. Non-specific lab manifestations are a low white count, especially a low lymphocyte count, mild to moderate thrombocytopenia, as you see here, moderate elevation of liver enzymes, and occasionally a DIC type picture. The degree of lymphopenia and thrombocytopenia has been correlated positively with a worse clinical outcome. Now, what can we say about lab testing? Does a rapid flu test do anything for you as far as avian flu goes? Well, the answer is not a whole lot. If you do the type of rapid test that distinguishes between flu A and flu B, and is positive for flu A, that could increase your index of suspicion. But these tests are not sensitive enough to rule out avian flu if they are negative. So if your patient fits the case definition, even if they have a negative rapid test, you need to move on to additional testing. So the first thing to realize is that that little vial of the rapid flu test can basically be thrown out after you've used it. It's not of any use for additional testing. Additional swabs must be obtained using viral transport medium, which needs to be transported on ice. And we want to emphasize that if you're suspicious of avian flu, all specimens should go to the public health laboratory, not to commercial labs. Also, the preferred specimen collection site is different. For regular flu, a nasopharyngeal swab is adequate, but for avian flu, the recommendation from the CDC is that you obtain a nasopharyngeal, a throat swab, and if at all possible, a lower respiratory specimen, such as a sputum, or if the patient was intubated, an aspirated specimen, because as I mentioned, the virus has such a preference for receptors in the lower respiratory tract. And specimen labeling is critical because when this specimen arrives to the public health lab, if it's just thought to be a seasonal flu specimen, viral culture will be performed. But if you label it suspect avian flu, they will do an RT-PCR, which is much safer for the laboratorian. Here's basically the precautions you take doing PCR, and this is what you use doing viral culture. This is a biosafety level 3 lab with enhancements at the CDC. Now, we are very fortunate that our county public health lab is quite advanced. In most places, you have to go to the state level to test for avian flu. Our lab has the H5 PCR primer that detects the H5 nucleic acids, and this reacts to both clades 1 and 2, and it also has a rapid turnaround time, usually within 4 to 6 hours. If the specimen is positive for H5, it will be sent to the state and the CDC, and they will, of course, reconfirm that the H5 is positive. The CDC also has a primer for the N1, so they will complete the identification of H5N1. It should be noted that there really are no other H5 avian flus that are a threat to man right now, so as soon as we got the positive H5 result, we would assume it was H5N1 until proven otherwise. And here's the final form. This form has to accompany the specimen, so again, downloadable from eMan, or we can fax it to you. A quick overview. For seasonal flu, no notification is required, although our surveillance department would, of course, like to hear about laboratory confirmed cases. Nasopharyngeal specimens are fine. You can use any lab you want. Viral culture is usually done, and there's no special paperwork. With avian flu, we want to be notified immediately, anytime, night or day, if you just suspect a case. And 3 specimens, preferably with a lower respiratory component, are recommended. They should only go to the public health lab. RT-PCR is the test of choice, and the form I just showed you should accompany the specimen. Now, the question of infection control for healthcare workers. We have to think about the 2 means of transmission for respiratory pathogens. There's droplet transmission, and there's airborne, otherwise known as droplet nuclei transmission. With droplet transmission, the particles are large. They're over 5 microns in diameter, so they tend to be heavy enough to fall to the floor within about 3 feet of a coughing, sneezing, breathing patient. And in this situation, surgical masks are adequate. Of course, if you're up close, you want to protect your eyes from any direct splashes. And examples of droplet spread infections are seasonal flu and pneumococcal pneumonia. On the other hand, airborne transmitted infections are carried by tinier particles that are less than 5 microns in diameter. They tend to stay suspended in the air for longer periods, and therefore N95 masks are recommended. Now, these masks, if you've ever tried them on, are rather difficult to work in. They're hot, sweaty, hard to talk through. You need to be fit tested for masks. You need to have a medical clearance if you have any cardiopulmonary disease, because the work of breathing is noticeably greater. So examples of airborne transmitted infections are smallpox, measles, and tuberculosis. The question is, how will avian flu be transmitted? Well, it's very reasonable to assume that it's going to act like seasonal flu. But because we don't know that for sure, some agencies are recommended that for healthcare workers that use the safest means possible. That answer, we still don't really have an answer to that question. One thing is it should be noted that certain procedures are aerosol generating, and virtually everybody recommends that an N95 be used for a suspect avian flu patient if you are doing an aerosol generating procedure, and that would be intubation, bronchoscopy, nebulizer treatments, or suctioning. So it's important to remind your patients that just because this is a novel agent, all the common sense things we know about infection control do not go out the window. I think we should be much more assertive, and at the front door of every waiting room there should be a box of ear loop surgical masks and a sign saying, if you are coughing or sneezing, please put this on. And there should also be dispensers of waterless sanitizer around the room so that when people don't have access to a sink, they can still perform hand hygiene. It's, the other thing that you might remind people, especially if they're caring for relatives that may have avian flu, is that the virus can be obtained in stool specimens. It is viable in the stool, and these patients have a lot of diarrhea, so enteric precautions should be practiced. Now, my personal soapbox is about these two things here. It's true that seasonal flu vaccine will not protect against the pandemic strain, but I think it's vital to remember that it's an important part of preparing the population for the pandemic. If you lower the prevalence of seasonal flu, first of all, you're lowering the risk of reassortment events. You're making an epidemiologic investigation far more feasible if you don't have two diseases that look virtually identical at the beginning. And we know that seasonal flu causes over 100,000 hospitalizations every winter in this country, sufficiently straining the healthcare system, which will be put under a double assault when pandemic flu arrives. So it'd be a good idea to administer seasonal flu vaccine. Also, in previous pandemics, secondary bacterial pneumonia was a common cause of death. Of course, in 1918, pre-antibiotic era and so forth. But nonetheless, we have a fairly low coverage rate of people that are really indicated to get this vaccine. For example, only 62% of seniors in this country have received a pneumovax. So consider that. For the sake of time, I'm just going to say that amantadine or amantadine are pretty much passé. The CDC just came out saying do not use them for seasonal flu because there's a 91% resistance to them, so they're pretty much not used anymore. Now, what about Tamiflu and Relenza? Certainly, the government's putting all its eggs into this basket. The federal government plans to acquire 80 million courses of Tamiflu in the federal stockpile. How effective is this drug? Well, there's not a whole lot of evidence if you really look at it. For seasonal flu, it seems to reduce symptoms by about a day. And there are a couple of studies that show that it may reduce antibiotic usage for secondary bacterial infections after influenza. And one study looked at all-cause hospitalization rates and found that was cut in half. Now, what you would like to see is hospitalization for respiratory illness after the flu and mortality. And I have not been able to find anything about that for this drug. Of course, we don't know how that translates for avian flu. It's, we've just got a handful of cases that have been treated, and it hasn't been terribly impressive, but many times it's been instituted too late in the course of the illness. There's also concern that the dosage and duration of treatment should be increased for avian flu, but that's just speculation. There's obviously no evidence to recommend that at this time. Well, I won't go into all this, but basically this is the virus getting through the nucleus, transcription, translation, and the new viruses are budding out here from the host cell. This is where Relenza and Tamiflu obstruct the process. And I think it's interesting to think about how neuraminidase inhibitors work. Here is the neuraminidase enzyme. You can see that it acts on sialic acid, also called neuraminic acid, where the hemagglutinin made the virus sticky to the host cell. The neuraminidase actually destroys hemagglutinins receptor so that it gets unsticky and can leave the cell. And I wanted to point out that Tamiflu and Relenza closely mimic structurally sialic acid. So you can see how they will lay in the active cleft of the molecule and inhibit its functioning. So here's a demonstration of neuraminidase at work. When there's no neuraminidase inhibitor on board, the new viruses are released to float off and infect other cells. When you do have neuraminidase inhibitors, you can see how they're all stuck to one another and stuck to the host cell and not released. Now, for a long time it was thought that there was no resistance, or that neuraminidase inhibitors, unlike the adamantanes, do not tend to incur resistance, and that's not exactly true. In Japan, they use a lot of Tamiflu on children with the flu, and they tend to use lower milligram per kilogram dosages for some reason. They have observed resistance to Tamiflu in up to 18% of children. Also, for avian flu H5N1, there have been a couple case studies in which it was seen that resistance developed right during the course of Tamiflu treatment. So, for example, one child had, on day 4 of her illness, had a mixed colony of virus, both wild type and resistant H5N1. And then on day 8, she had only resistant virus, and that was correlated temporally with the increased viral load and a clinical demise. So, you know, the take-home message, I think, from this is that we don't want to squander using Tamiflu for regular flu in people that have no risk factors, because probably the most it's going to do for them is shorten their symptoms by a day if it's instituted within 48 hours of onset of symptoms. So by all means, for people at risk of complications, treatment and prophylaxis are entirely appropriate for seasonal flu. But for the healthy 30-year-old guy who just wants to get back to work a day earlier, perhaps we should be reserving this drug so that it's still working if and when we need it for pandemic. Briefly, just isolation and quarantine are going to be important measures. The recommended duration for isolation is 14 days, although children and the immunocompromised shed virus longer. Quarantine for well people who've been exposed is 10 days. And I will say that for the World Health Organization Phase 3, quarantine of asymptomatic people is not recommended. Only isolation has been recommended by the CDC. Now, all that will change in Phase 6 when human-to-human transmission is observed. And of course, it's a delicate balancing act to think about the rights of individuals and protecting the community. The public really needs to get the message that they need to think about taking care of themselves. It's, you know, institutional medicine and the government are not going to be able to save people. And what the federal government is trying to get the message out is that you should become more autonomous. That's why they're talking about food and water stockpiling. During the wave of the pandemic, each wave tends to last about 8 weeks. It'd be a good idea not to go to the store every 3 days. So they're trying to get people to plan for these things. You know, I don't know how effective that planning will be. Just as an aside, you know, there's the movie about avian flu is going to be on primetime TV tonight, so you might prepare to get a lot more questions from your patients and family members and friends. Quick word about the vaccine. Why aren't we churning out pandemic vaccine right now, since we feel that this is coming? The main reason is we have to wait until human-to-human transmission develops to know the exact strain that we should be making the vaccine against. So the plan is as soon as we get to Phase 6, the vaccine manufacturers go into action and start cranking out vaccine. Well, you know that our vaccine industry is kind of rickety and not too robust, but the government, both here and in Europe, is trying to provide incentives to vaccine manufacturers. Also, it'll probably take, well, will take 2 shots a month apart to induce immunity. So just as a child getting his or her first seasonal flu vaccine requires 2 shots, we are all like children with H5N1. We are all immunologically naive. Now, you may have heard about the recent clinical trial on a generic H5N1 vaccine. They used a strain from Vietnam in 2004. That's clade 1. So remember, human deaths have also occurred from clade 2. So whether it would be effective against that variety is unknown. And it was an important study to do, given that it was the first attempt to do this. The results were not stellar. It required 12 times more antigen than is used for a seasonal flu vaccine. And of the healthy, relatively young people, only about half of them developed antibodies. So at this amount of antigen, they could not make vaccine for a lot of people. But at least it was an initial study to see if it worked, and it was safe. There's feverish research on new vaccine technology using cell culture, using adjuvants such as alum and other experimental things to make a little bit of antigen go further, reverse genetics. They are also looking for the holy grail, which is the universal influenza vaccine. If we could find something that did not change between the different strains, we might be able to make a long-lasting flu vaccine. And one area that's highly conserved is the cleavage site in hemagglutinin. It's identical for all influenza A's, and there are only 2 amino acids different for influenza B. So some work is being done to try and create a vaccine based on that site. So what is our strategy for the pandemic? Well, we're not going to have vaccine for at least the first 6 to 9 months. So that's where we're going to be buying time. So public messaging about social distancing, hygiene, and restriction of close contact, quarantine and isolation is needed, and judicious use of antivirals. There probably will not be enough to use antivirals prophylactically, so it will likely be treatment of cases, and that's where, working with the health department, we can help you facilitate decision-making, since we have the H5PCR available here in town. After 6 to 9 months, when the vaccine's available, the county has the plans to institute a number of points of distribution throughout the county, and these will be rapid kind of walk-through vaccination sites that will be operative 24 hours a day to get the vaccine to as many people as possible in a hurry. Now, surge capacity is a major concern. Hospitals get HRSA grants, which is federal money for bioterrorism, and that's allowed them to institute buying equipment and setting up plans for disaster planning. So surge capacity tents that can be set up in the parking lot that basically create an extra wing of the hospital. They have negative pressure rooms, additional equipment, and so on. The goal for the HRSA grants is to develop capacity to treat an extra 500 persons per million, or 1,500 for San Diego County. The CDC's modeling suggests that there will be probably about 3,000 to 5,000 additional hospitalizations in San Diego County for avian flu if we're in a pandemic. So this does not cover the whole need, but it's certainly a step in the right direction. Also, this strategic national stockpile can be released in 12-hour push packs that will arrive here within 12 hours. The governor has to sign a declaration of emergency, and this will have the stockpiles of antivirals, medication, ventilators, etc., and pods will also be used for that. Oh, phew. I think I'm done. There's a lot of great references. I'd encourage you just to explore the web, and you'll find a lot going on there. And for your patients and friends, family, refer them to these sites. There's a lot of very specific advice for different groups of people, different needs, and so on, so you can help them become educated on it. And again, I'd like to remind you that for any infectious disease concern, we are available to you 24 hours a day to try and help you with clinical problems. Thank you very much.